start today's seminar on improving stroke care in low and middle income countries. For the session today, our chair would be His Excellency Professor Dr. Muhammad Iqbal Chaudhry, Director ICCBS and Coordinator General COMSTECH. Our co-chair would be Dr. Anjum Farooq, President Pakistan Stroke Society, who is here with us online right now. And for our moderator, it would be Dr. Sajid Hamid, physically present here. To begin the seminar today, we will begin with the national anthem. For the tilawat now, I would like to invite Mr. Azizur Rahman.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم.
Jazakallah. With that, I would now like to invite our moderator for the session, Dr. Sajid Hamid.
Thank you, Mr. ICCBS. Assalamu alaikum everyone and good afternoon. I'm Dr. Sajid Hamid and I'm the moderator for today's event. Today's seminar is about improving stroke care in low and middle income countries, and it is organized by COMSTECH ICCBS. I will request Professor Dr. Mohammad Wase, one of the renowned neurologists of Pakistan, for the opening remarks.
Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. So I would like to welcome all the participants, speakers from throughout the world. I think this is one of the most important topics related to health and disability and death in the world. And stroke, especially in the low and middle income countries, is the topmost cause of death and disability. And I'm really thankful to Dr. Iqbal Chaudhry and COMSTECH that they have taken up this topic. This is very relevant to the OIC world and especially to the middle income countries, upper and lower middle income countries both. And hopefully that this workshop, this seminar will translate into meaningful actions throughout the country. And the COMSTECH is not only working on improving healthcare throughout the member countries, but improving technologies, health technologies, especially to improve the outcome of the health of the people. So this workshop is very important. This topic is very important. And in this workshop today, we will not only learn the burden of the disease, but how we can collaborate each other in terms of improving stroke care, in terms of stroke research. And one of the very important topics in our part of the world is stroke in women, because women are more affected with a stroke as compared to men, and that's a very less acknowledged area. So we have introduced this topic, and this is, I think, is going to be very important. And hopefully, this workshop will translate into meaningful actions and policies across the OIC countries. So I'm again thankful to Comstech and Dr. Iqbal Chaudhry for organizing this workshop, and I'm thankful to all the speakers. We have speakers from Iran, Middle East, and Canada participating at this course, and we have participants from Egypt, panelists from Egypt and other parts of the world who are being panelists for this course. So this is, I think, it's a kind of global seminar, and we have more than 300 participants. Hopefully, will be attending throughout the world for this webinar. So hopefully, this will be a very important learning exercise, and this will translate into meaningful actions and policies. Thank you again.
Thank you very much, Professor Dr. Mohammad Wase. Now I will request His Excellency, Professor Dr. Mohammad Iqbal Chaudhry. He's a renowned scientist with more than 800 publications. He's recipient of many awards, including Hilal Imtiaz, Sitara Imtiaz, Tamja Imtiaz, and last year he received Mustafa Prize. So I will request His Excellency for the welcome address.
Dr. Saab, thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Let me first begin by thanking my very dear friend, Professor Dr. Wase. Dr. Wase is a very renowned scientist, and he is also humanist by nature. He's someone who has this passion of serving, and I think this is one of the greatest strengths of his personality, that he wished to serve everyone. And with this important resource on our dispense, we have requested Dr. Vase to actually develop a program which is coherent and which actually addresses major problems. So he is currently working on an OIC-wide program, which will include several workshops in different countries of the world, including least developed African countries. Now, you may know that COMSTECH is a standing committee for 57 ministers of science and technology, and some of you have traveled to Islamabad, 24 hours. So we went all the way to Islamabad to see this beautiful headquarters of COMSTECH, and COMSTECH is the premier organization which is responsible of science and technology cooperation among 57 countries. Now, these 57 countries are spread over 4 continents, and they are in different ladder of development. Some of them are extremely low in terms of development, and that is where we need to have actual impact. And what we intend to do is to develop capacity of our brothers and sisters in least developed countries, and neurological sciences are extremely important, for which Dr. Vase is leading the whole efforts. We intend to have several things. Of course, we're planning to go to Africa, to at least 2 countries this year, inshallah. Dr. Vase leading those teams and training people in neurocritical care, including stroke. And also, he is in the process of compiling the directory of neurologists in the OIC countries. So do help him, and if you have information, please do share with Dr. Vase. Also, we're planning to have a consortium or alliance or network of neurological societies in the OIC countries. So we have several of these programs, and the mega programs of COMSTECH include 500 fellowships for Palestinian scholars, 200 fellowships for African women scientists. So if you are not a woman, you are in disadvantaged positions. We also intend to spend about $1.5 million on research projects. So we would be spending a lot of money on Africa now, and our focus for next 5 years would be largely Africa and Central Asia. And we will be conducting many of these events in the field of ophthalmology, dermatology, and neurology. Of course, neurology is extremely important. This is a field in which we intend to have several programs. This program is very, very important. Thank you for putting together a very important program. I'm sure that you would learn from some of the best experts available. And I'm grateful to not only my dear friend, Professor Dr. Vasi, but also to the Pakistan Stroke Society. And we have Dr. Anjuman online also, and some of the other doctors and resource persons from other countries. So thank you very much for being part of this exciting learning experience, and hope that you would be able to benefit, enjoy, and become alumni of a larger network of people who are benefiting from COMSTECH activities. Thank you. Thank you.
Thank you very much, Professor Dr. Mohammed Iqbal Chaudhry. Stroke is indeed a leading cause of disability, and we are thankful for the COMSTECH for taking this step. Mutual cooperation is needed between different countries to help each other in solving this problem. Now, for the next presentation, I will invite Professor Dr. Mohammed Wase. Let me tell you some few words about him. Professor Dr. Mohammed Wase is a teacher and supervisor for more than 100 FCPS candidates. He has more than 300 publications, and the best thing about him, he promotes neurological awareness throughout the world, especially in the remote countries of Pakistan, where there were no neurologists and nobody's known about these diseases. So the title of his talk is Burden of Stroke in Low and Middle Income Countries. Professor Dr. Mohammed Wase.
Bismillahirrahmanirrahim. Now, this is one of the most important topics these days related to healthcare. And this is not only most important for the World Stroke Organization, it's very important for the World Health Organization. And what I will do is to introduce you first general information that what is low and middle income countries, because a lot of people don't even know what low and middle income countries are and what's the burden of stroke and what are the challenges related to stroke in these parts of the world. And most of the OIC countries, they are in the upper and lower middle income countries, and what we can do, like what interventions needed to be done to improve stroke care, not only in Pakistan, but in these low and middle income countries. So this is the topic of today's presentation. So now this is a low and upper middle is basically a definition of World Bank. So there they define that what countries are low income countries, and they have defined the world into 4 categories. So there is a low income country category which has 27 countries in it, and that these countries, they have like a per capita income of less than $1,000. The lower middle income countries is 1,000 to 4,000 US dollars, and there are 55 countries. Upper middle income countries are 4,000 to $12,000, and there are 55 countries. And high income countries are $12,000 or more, and there are 80 countries. But if you just look at the population, just don't count the number of the countries, out of 7.8 billion population of the world, 6.6 billion lie in low and middle income countries. So they have the largest population burden across the globe. And that's why when we talk about low and middle income countries, we are almost talk about healthcare of about 80-85% people in the world, which are kind of underprivileged, and the disease status is not well known, and the care is fairly compromised and poor. And what are the countries? Low income countries, you can see 0.7 billion population. So they are less in number, 27 only, and low population. But they have Afghanistan, and there are 27 countries. You can just see the list of those countries. So we will be talking about healthcare models and improving stroke care in these low income countries too. And but our most important area would be upper and lower middle income countries, which is upper middle income countries is like 2.5 billion, which is again 55 countries. And this has a long list of these countries. Pakistan is also part of the upper middle income country. And then we have lower middle income country, which is 3.3 billion population. Again, these are 55 countries, and they constitute the highest population share of all the countries. And high income countries, which are 18 number, but the population is low, it's 1.2 billion. So out of 7.8, 1.2 billion is in these high income countries. So this is mostly Europe and American countries or Far East like Japan, Australia, and those kind of countries. What is the burden of stroke right now? First ever stroke is 16.9 million population every year. Stroke survivors is 33 million at this point. Stroke related deaths is 5.9 million every year. So 6 million people die of stroke every year. And you can just compare with the COVID numbers, because now you pretty much know the COVID numbers every day. You have the number of COVID. So even with the total COVID numbers, we are not close to 6 million deaths. You have a lot of patients who are affected with COVID, but the death rate is still less than what happens with stroke every year. So for example, stroke in Pakistan, we have 400 people die of stroke every year in Pakistan, every day in Pakistan. Not a single day in the last 2 years when you have COVID related death of 400 a day. So overall death rate related to stroke is very, very high as compared to COVID or any other condition. And those who survive, half of them, they become disabled. So their stroke is the number one cause of disability in the world. So that is the most important thing, that a lot of people die, which can be prevented, and a lot of people become disabled, which you can prevent them from becoming disabled. So it's something which you can intervene to protect not only life, and you can save lives, and you can save disability by just doing the right intervention, which we'll be discussing in the next couple of hours, because that's the topic for today's session. And this trend is increasing in low and middle income countries. That is the biggest problem, that in the high income countries, it's going down. Stroke frequency, stroke incidence, stroke prevalence, and stroke related mortality is going down. But in low and middle income countries is going up. That's one thing. Now overall stroke mortality has decreased because of the better care. So it used to be 37% in high income countries. So it has decreased, and low income countries it has also decreased, but it has decreased less, like 20% reduction in mortality. So mortality has decreased, but still you have a very high burden of mortality and disability related to stroke is in the low and middle income countries. Now most of the burden related to stroke right now is in low and middle income countries. So out of all strokes, 68% of new stroke is happening in low and middle income countries. So 70% stroke is happening in this part of the world. Of all the stroke population in the world, 52% population lives in this country. 70.9% stroke related death in the low and middle income countries, and 77% of disability in this part of the world is related to low and middle income countries. Now, why we are talking about this? Because once you know this number, you think of that we have to do something, because that's why the numbers are that they make you think that we have to do something to get these numbers down. There's just a lot of disability, and especially in our part of the world. And it's now not only affecting the old population, because we used to think that stroke is a problem of the elderly, 60 years old, 55-year-old, mean age is still 63 years old. But now children and young men and women, they are being affected with stroke. So like in 2010, 5.2 million stroke were in children below 20 years of age. So that's a huge number in children. And young and middle-aged people from low and middle income countries, they constitute a huge number. So 78% of the young stroke in the world is happening in our part of the world. So in our part of the world, young people are having stroke. And why they are having stroke, we'll discuss that in few minutes. Because if you don't prevent them from having stroke, this number is going to go up, and that's going to be more troublesome and more disability related to stroke. in this part of the world. A mean age of stroke is even younger. If you can look at this graph, you can see that if you the first graph on the side is on the left is high income countries, then low and middle income countries, and you can see the age difference. The stroke happens in Western world at the age of 73 years, now 74 years, and in our part of the world is 69 years. So it's 5 years younger as compared to Western population, high income countries. Stroke prevalence of a stroke is 73 years as compared to 68 years. And stroke mortality, uh, age for high mortality stroke is 80 years in high income countries as compared to 72 years in low income countries and middle income countries. So our patient population who is having a stroke is younger, they have more death, and they have more disability at a younger age, and that's what accumulates. Because if someone at the age of 45 they become disabled, so if they are going to live for next 20, 30, 25 more years, so they will be disabled for my next 25 years. So if you are accumulating a lot of disabled persons in the country with stroke, that's going to increase the number of disabled persons in your country. And this is what happening in Pakistan and other developing countries, that every year there is a 3%, 2% increase in number of disabled persons. And the top cause of that disability is stroke and trauma. These are the two most important causes. So stroke is preventable, trauma is also preventable. So you can prevent disability in the country if you can just control those risk factors, which are very important. So what are the risk factors? And this is, I think, one of the most important message if you want to learn from this presentation, is the only way to decrease the incidence of stroke is to reduce the risk factors. Reducing risk factors means reducing stroke burden. Controlling the risk factors means you can reduce the stroke burden. Now there are 10 risk factors: hypertension, smoking or tobacco use, diabetes, waist to hip ratio, that means obesity, diet risk score, physical inactivity, alcohol, psychosocial stress, and depression, cardiac causes, and there is a apolipoprotein B to A1. These are the 10 important risk factors, and this came from interstroke study that was a global study. We were part of that. So they concluded that these are the 10 risk factors. But if you cannot intervene on all 10 risk factors, WHO has identified most important risk factors. And they are basically 5 or 6 risk factors, which if you can control, you can reduce the burden of stroke by 50%. 50% reduction in stroke burden by controlling or partly controlling some of the risk factors. So what are the most important? The most important risk factor out of all risk factors, the most important is high blood pressure. Even if you can just do one thing, is to control high blood pressure of a person, you can reduce the stroke burden by 30%. By just 5 millimeter control of diastolic blood pressure, you can control or you can reduce the burden of stroke. So this is single most important intervention which we'll be discussing, that how we can reduce the burden of stroke in Pakistan, where 1,000 people have stroke every day. You can bring it down to 500, 600, 700, 800, or in other low and middle income countries, how can you reduce the burden? By just controlling blood pressure. The second most important cause of stroke in our part of the world is tobacco, smoking, and other tobacco abuse. Like in Pakistan, people use gudka, people use niswar, other forms of chewing tobacco. In Western world, they mostly have smoking, but in our Pakistan and India and other developing countries, we have a double burden of smoking and chewing tobacco. So the second most important intervention as per WHO is that if you can reduce just tobacco abuse, you can pretty much reduce the burden of stroke and non-communicable diseases related to death. The third one is diabetes. If you can screen the diabetics, so in Pakistan, for example, there are 10 million diabetics out of 224 million population. So this is a huge burden. If you can screen them, if you can treat them, previous stroke is an important risk factor, and atrial fibrillation, that's also another important risk factor, especially in elderly population. So in elderly population, you have to not only screen those patients for atrial fibrillation, but also treat so you can prevent stroke. So these are 6 risk factors which WHO has identified that you can intervene, you can screen them, and you can control to prevent the risk of stroke in developing countries and especially low and middle income countries. Now, one of the important factors in our part of the world and low and middle income countries is that a lot of stroke goes unnoticed and undiagnosed. People have a stroke, people die, no one knows that what happened. And how you can learn about those stroke, especially in our part of the world, because a lot of people don't even have a death record, they don't even have a death certificate, there's no diagnosis of cause of death on the death certificate. So at this point there's no surveillance that how many people are having a stroke. They are all just estimates. So the WHO has started a surveillance program for stroke that's called STEP program. And that STEP program is basically for low and middle income countries. And basically they have 3 steps to identify patient with stroke and then accumulating all data to identify that how many patients are having stroke. So this is first thing I think we should start in the low and middle income countries is a stroke surveillance program. Unfortunately, we don't have a surveillance program in Pakistan, so we are just relying on the estimates, but you can apply this STEP program in Pakistan and other parts of the world to accurately identify that how many patients or people are having stroke. And basically, another important thing is screening for stroke risk factors. At this point, there's no screening guideline or module. People, when they have a stroke, then they find out that they have high blood pressure for 10 years, they did not know. People, when they have renal failure, they find out that they have diabetes for 10 years, they did not know. So there should be a screening mechanism. Now, WHO says that everyone who is 40 years old, they should check their blood pressure, they should check their cholesterol, and they should check their diabetes, that if they don't have diabetes or not. In Pakistan, I think that everyone who is more than 25 years old, we should check for that. And unfortunately, a lot of people who are educated, like college students, university teachers, we see them, they have never checked their blood pressure. They did not even know what their blood pressure is. They did not even know what their sugar is, what their cholesterol level is. This is something like you worry about a lot of things. If you have a car, you kind of take care of your car, you check the oil and everything. You have a motorcycle, you check everything. But majority of people never ever check their blood pressure or screen themselves for high blood pressure or sugar or cholesterol. So this is something which is a basic a screening tool which we have to insert in our healthcare model. And not only healthcare model, but it's just a public awareness that everyone has to take care of their health, and something they have to do on a yearly basis. If they are 40 years old, 35 years old, is to check their blood pressure once a year at least, and check their sugar level is just a blood test, and a cholesterol level or lipid level to just see that if they are not dyslipidemic, or they have to check their weight. A lot of people are obese, they have very high BMI, which is a very high strong risk factor for stroke. So these are some just basic important things which we have to start screen ourselves. And there are mobile apps. There's a mobile app which is called Riskometer, stroke Riskometer. You can just go to mobile app and put your data, that your height, your weight, and your age and everything, and that will tell you that what is the risk of a stroke you have. And then if you have more data like blood pressure, sugar, cholesterol, then they will tell you exactly that is the risk of stroke you have. So these are available, but something you have to kind of incorporate this screening mode in the whole population. Every person who is 30 years or 40 years old age, they have to look that they do have any of those problems or not. And the second one is lifestyle, because there are certain things which we know for sure they cause stroke. For example, lack of exercise, tobacco, obesity. So this is a disease also. Using tobacco or being addicted to tobacco is a disease that has to be treated, that has to be screened. If you are obese, then that is a disease. If you don't exercise and you don't do any healthy activities. So that's kind of a disease. It has to be treated. And this is something which is very important for health screening. And this is something which we have to do in our population. And this is not doctor's responsibility only. This is the responsibility of the whole community. You have parents, you have brothers and sisters, you have anyone who is 35 years old, you have to make sure that they are screened for stroke. The third issue in developing countries, especially in low and middle income countries, is the diagnosis. Now, to diagnose stroke, diagnosis for stroke is a clinical diagnosis, but you need a CT scan to diagnose that if the stroke is ischemic or it's hemorrhagic. It's because of the ischemia or because the management is different. So you need a CT scan. Now, if you don't have CT scan, then you cannot appropriately diagnose stroke. That's one thing. Then you need MRI if you want to diagnose, like look at the blood vessels, the type of stroke and everything. You need laboratory tests. You need to check the glucose, hemoglobin A1C, lipid profile, renal function. You need EKG, which is heart rhythm. You need echocardiogram to look at that, which is kind of a structural evaluation of heart. Holter monitor is also a kind of rhythm monitor for 24 hours. You need a Doppler ultrasound. So these are the equipment or technology you need available in your hospitals, in a local hospital. And this is something what stroke societies they do. They kind of advocacy, they become advocate that these facilities should be available at every local hospital. For example, in Pakistan, there are 130 DHQ hospitals, but these facilities are not available at DHQ hospital. For example, if someone has a stroke in Tharparkar, there is no CT scan in Tharparkar, so they have to drive 4 hours to get a CT scan to see if they have a stroke or not. Though Tharparkar has a lot, they have the biggest coal mines in Pakistan, they have a lot of other things, but they don't have a CT scan. So this is something which is technology. You have to put this technology in the local areas to diagnose people with stroke. This is how you are going to decrease the mortality related to stroke. And this is something which is very important in low and middle income countries, that they kind of update or upgrade themselves with this technology. The next issue in these countries is primary prevention. Secondary prevention is someone who already had a stroke. Now, primary prevention is you prevent someone from having a stroke when they have no stroke. And this is basically the number one intervention. WHO says the tobacco control. This is the most important intervention. The tobacco burden is going up in Pakistan. You have to reduce the tobacco burden in Pakistan. Number two, hypertension diagnosis. Number three, diabetes. Number four, exercise. You have to promote exercise. I would ask all of you that if you want to be healthy, you don't want to have a heart attack, you don't want to have a stroke, start exercising. Just walk for 5,000, 6,000 steps every day. Just take this time from your all of whatever schedule you have. And you have to promote this healthy living across societies, communities, across families, if you want to prevent them from having a stroke. Another issue which is kind of more in Pakistan is salt use. We have probably the highest burden of hypertension in country. And one of the reason is that we use a lot of salt. In Pakistan, even people like put salt in the desert and in tea and coffee and a lot of salt. So salt intake is one of the important predictors of high blood pressure and stroke, and WHO has identified it's one of the important intervention for stroke prevention and NCD prevention. In a lot of developed part of the world, they don't even put salt on the table. You just cannot find the salt on a restaurant table. You have to ask for salt, otherwise you won't get it. So salt use is important. I think we have to consciously reduce the salt reduction. Atrial fibrillation is important, and dyslipidemia is also important, which I told you, for stroke prevention. Now, the other thing is medications. For stroke prevention, you have to take certain medications. It's not everything you can just do without medication. So if you need medication, for example, if someone has high blood pressure, they have to take medications. You cannot just control your blood pressure by meditation or by any other thing. You have to take blood pressure medication. If you have high cholesterol, you can control partly by diet control and exercise, but still if you is high, you have to take medication. If you have diabetes, you have to take medications. If someone has a stroke, they have to take blood pressure, antiplatelet medication. So these medications are also important. And this is one of the major causes of stroke in low and middle income countries. A lot of people who are diagnosed with high blood pressure and diabetes and dyslipidemia, they are unable to afford medications. Medications are sometimes not available in some parts of the country, and sometimes they are very costly that people cannot afford it. And that's what makes the compliance issue. There are a lot of people who are diagnosed, they are not taking right medication, they are not compliant. One of the problems is behavior, because people are not very, they don't give very importance to taking medication. That's part of the behavior. But if sometimes they cannot afford it, sometimes they are non-compliant. Sometimes even if they are taking medication, they are not monitoring that if the medication is working or not. A lot of people, they are using poly medication. So there's a suggestion that you could just combine all the medications in a poly pill that may improve the compliance. So these are the things. But this is something very important, that people who have these risk factors, you have to make a system in the country. The medications should be available. They should be affordable, that everyone can afford it. If people who are unable to afford it, the government should supply those medications to those persons who cannot afford medication. Because otherwise they are going to have a stroke and they will become disability. They will become disabled, and that will be a burden on the whole society. So this is the responsibility of the whole society and community, that if someone cannot take medications, the governments or the organizations, like for example, COVID vaccine, WHO is supplying COVID vaccine, COVAX is supplying COVID vaccine. We have received, I don't know, 10 or 15 million doses of COVID vaccine free of cost from different parts of the world. We are giving COVID vaccine for free. But why cannot you give like blood pressure medication for free? If you can give COVID vaccine, you can give blood pressure medications for free. You can give blood cholesterol medications for free, not to everyone, but someone who cannot afford it. But there should be a system in the low and middle income countries if we want to protect or prevent a stroke in our part of the world. Now, next is a community-based education program. I think this is very important. There are many research studies which have shown that if you educate the community, you just educate the people, you just make people aware that they are at high risk of a stroke and they should do these things. A lot of people start doing those things. So this is important. And the studies have shown that you can reduce the burden by 11%, 7%, 12% by just improving the awareness among public, that they should check their blood pressure, they should exercise, they should not smoke, and those kind of things. Just awareness makes a lot of difference. There's a very important program which is called FAST, which is very well known in Europe. For example, if you go to a school, a high school, and you ask students about the FAST, everyone would know what FAST is. As FAST is basically recognition of stroke symptoms. There are 3 stroke symptoms. So there's drooping of the face, there is weakness of the strength, there is slurring of the speech. So what happens that if there is weakness of the arm, drooping of the face, slurring of the speech, everyone knows that this person is having a stroke. So you educate all the children, the public, laymen, they all know that if someone has one of those 3, they are having a stroke, they should go to the hospital. So this is an awareness thing, that you to make people aware about the acute stroke symptom. Now you have social media, everyone has a mobile, not everyone, but most of people have a mobile, so you can connect to them. There are a lot of digital health initiatives. So you can use this social media to improve public awareness about health. Public is very much aware about a lot of things, but they are very least aware about their health and the risk of their health. So this is something which is a community responsibility, that we make public awareness. The other thing which is important for those who have a stroke is treatment of the acute stroke, because by the time you do all the interventions and reduce the stroke burden, still there are 1,000 people who are having a stroke every day in Pakistan, and millions are having a stroke every day. So there is an acute stroke treatment for those who have a stroke. And if you do not apply that acute stroke treatment, the mortality is very high. For example, if those people who are unable to get acute stroke treatment, mortality is 40%. 40% people who have a stroke, they are going to die if they don't receive the right care. If they receive the right care, you can reduce the mortality by from up to 15%. So 25% people you can save. And not only you save the death, you can also save the disability. So if you want to prevent death and disability in patients who have a stroke, you have to do these things. You have to make stroke units in your hospital. Stroke units improve outcome of stroke patient. The TPA is a medication which can be given in less than 3 hours. If someone has a stroke and they don't have a bleed, you can give them TPA. The outcome is better. Thrombectomy is a treatment which you can give within 24 hours, but that needs a lot of expertise. And you need to dysphagia evaluation. Don't feed person who have a stroke because they are going to die of aspiration pneumonia. So you have to see that if they need NG tube or not. If they need, you can put NG tube. You can prevent death by just doing this acute stroke care. And we have seen that patients who get acute stroke care, death rate goes down from 40% to 15% or 16%. So you can prevent that many number in like 3 days of stroke care with just good nursing care and good stroke care. This is something which is important for the low and middle income countries. This is cost effective to put a stroke unit in the hospital. Every district hospital, every civil hospital, every hospital which is seeing a stroke patient, they should have a stroke unit, because that single intervention improves outcome in patients who have stroke. So this is something which has to be done. Rehabilitation is very important. There's an inpatient rehab, there's outpatient rehab, and now there's a family rehabilitation that a lot of people, family members, they do rehabilitation. Our objective of the rehabilitation is that this person who had a stroke, they should go back to what they were doing. That's called community reintegration. If someone was on job, we want to make sure that he goes back on his job. If someone was a shopkeeper, he should go back to his shop. If a woman was leading the house, she should be able to lead the house. So our objective is to get them back on their foot and get them back on their job or on their daily activities. This is the objective of the rehab, not just doing physiotherapy itself, but to put them back on their life. And that needs a required comprehensive rehabilitation program, which needs to be done in all parts of the world. And that's one reason why the developed world, they have very good outcome of stroke, is that they have a comprehensive rehab program. This is also important in terms of low and middle income countries. We have a very high long-term mortality, 40% in 1 year. And you can reduce this mortality by rehabilitation, by compliance. A lot of people who have recurrent stroke, they just stop taking medication. They get better and they thought that now we are better. They stop taking medication. So they require post-discharge counseling, they develop post-stroke depression. So these are the things you have to take care of. Now, World Stroke Organization has identified a map that what kind of stroke care you need, and you put that stroke care in your model. For example, there's the advanced stroke care, there's the essential, there's minimal. And we start with minimal, that what is the minimal stroke care that should be done in a country where you have a stroke. Public awareness, educational materials, videos, emergency alert systems, acute care, fast training. These are something which you have to kind of incorporate in your community to educate and make people aware about the stroke risk factors, stroke symptoms. And then you have to have these things at least. You have to have BP apparatus in your doctor's office. You have to have a glucometer, a ECG machine, something like if someone has a stroke, you can refer them to a hospital for stroke care nearby. You have to have a screening tool for the stroke risk factors, and you have to know how to check the blood pressure and monitor blood pressure and sugar, those kind of things. So these are the things every doctor has to learn if you want to decrease the progression of stroke in this part of the world. There are certain medications which has to be present in every hospital or patients who have. This is minimal, like this is the minimum you can do in a hospital to prevent stroke or stroke related death in your area. Now, if you are a higher level, like for example, you are kind of in a district headquarter or something like that, then you do all that things which are previously listed, and on top of that, you have to have a CT scan. So this is essential for a stroke care, that you have to have a CT scan machine, you have to have a stroke unit in your hospital, a cardiac monitoring, ECG, blood laboratory testing. So these are the things which you have to incorporate, and these are available in many large hospitals across the country. but not in all parts of the OIC countries and low and middle income countries. That has to be incorporated. And this is a global responsibility. This is not a country's responsibility. Like, for example, there are global organizations who are donating vaccines, who are donating many things to these developing countries. So they have to donate CT scans, expertise, EKG machine, echocardiogram to incorporate that in the healthcare system. So this is something which has to be done over a period of time if you want to decrease the burden of stroke. The medications, now for essential level care, you have to have TPA. For example, TPA is not available in Pakistan, but the government doesn't supply the TPAs. So TPA, that's why Pakistan, only few centers in Pakistan who are providing this essential or secondary healthcare. Most of the hospitals are just minimal healthcare hospitals, but we have to upgrade these hospitals. Now the advanced care is basically when you have all the facilities. You have a lab, you can do thrombectomy, you can do Doppler and everything, which is only available at only few private hospitals in the country. It's not available at any government hospital. It's not available at any public hospital in Pakistan. So only few private hospitals, they provide this facility, but that's only for very selected population. You have to make these facilities available for general public and population. And this is, I think, very important that all the medications and facilities should be available. So in conclusion, stroke burden and mortality is very high in low and middle income countries. We need cost effective interventions to improve stroke care. We need awareness among doctors and nursing staff and a lot of advocacy to appeal the government to improve stroke care. We need short-term and long-term strategic planning. And we need a collaboration among low and middle income countries because we can learn from each other. And OIC and COMSTECH is a very important platform because they are connecting these 57 countries who are part of the OIC. So at least we should target that how we are going to improve stroke care in these 57 OIC and COMSTECH member countries. And hopefully we can get some of these message across and improve stroke care in this part of the world. Thank you very much. Thanks for listening. And we will have questions in the panel discussion session.
Thank you. Thank you very much, Professor Mohammad Wasek, for highlighting the high burden of stroke in low and middle income countries. As rightly said, we are facing three problems. One, decreased income. Two, high rate of population. And three, rising stroke incidence. So it is a high time that all the countries in the low and middle income countries desperately they take some measures to reduce this burden of stroke. Now for the next presentation, our presenter is from Iran. He is the director of Tabriz Neuroscience Research Center and has worked a lot in the field of stroke, not only in Iran but throughout the Asia. So I welcome Professor Mehdi Faroudi, and his title of talk is Secondary Stroke Prevention in Low and Middle Income Countries. We cannot hear you, sir, but we can see your slides. Please unmute yourself, sir.
Yes, do you have my slide now?
Yes, we can hear you and we can also see your slide.
Okay, I shared. Okay, you have?
Yes, yes, we
Okay. In the name of God, hello everyone. Thank you for this opportunity. Thank you, Dr. Bassey, for inviting me. My presentation title is about secondary stroke prevention in low middle income countries. I don't have any conflict of interest. As Professor Bassey explained about World Bank classification, you see here the map in the area. Professor Bassey said about low-income countries. You see here showed with dark purple. mostly located in Africa, you see here, and Afghanistan and Madagascar. Low middle income countries showed here with light purple, you see here again, mostly located in Africa, and some here Kenya and Malaysia, Indonesia, India, and Pakistan, Iran, and Mongolia, and here Ukraine, and some part in South America. About upper middle income countries, you see here showed with light green, mostly in South Africa, Mexico, and South Africa, Libya, mostly in Europe, and China, South Korea, and about high-income countries, you see here showed with dark green, mostly in US, Canada, Greenland, Chile, and Saudi Arabia, some West Europe countries, Australia. Professor Bassey said about burden of stroke based on publication in International Journal of Stroke in 2010, you see here, annual burden of most common diseases predicted until 2030. You see here about stroke will be about 7.8 annual deaths in 2030. And because of, as you know, high incidence of stroke, there is a stroke World Stroke Organization established about 2004, and every year there is a slogan. In 2010, the slogan was about, you see here, 1 in 6 people worldwide will have a stroke. This slogan changed 9 years later to 1 in 4 of us will have a stroke. You see here increasing globally incidence of stroke. Other prediction last year published by World Stroke Organization, you see here, based on this prediction, in 2050, we will have an annual death of stroke about 12 million. If usual situation continue, we have a more annual deaths about in 2050. It is threatening situation. What about secondary stroke incidence? Based on publication, we have a wide range of stroke recurrence. In first year, we have about 7 to 20%. In 5 year, the first 5 year, we have a recurrence of about 60 to 35%. And in 10 year, based on publication, we have a recurrence of 14 to 51%. In this wide range means that effect of secondary stroke prevention, if we have a good prevention, recurrence will be low, and if we don't have any good prevention, unfortunately have a more recurrence. About secondary stroke prevention strategies, Dr. Bassey said more, but generally we have, based on EBM guideline, healthy lifestyle is very important, such as having a healthy diet, appropriate physical activity, no smoking situation life, and all of this is important for primary prevention, but also for secondary prevention. And control of high blood pressure is the most important strategy, as Professor Bassey said. Other risk factor modification is very important. About drugs, antiplatelet and lipid lowering therapies, especially statin, is very important. Recently, this drug as a polypill using, and it can be easily used and continue this drug by people. About anticoagulation, it is very important in special patients such as AF is important for secondary prevention of stroke, and surgery stenting is again important for integrated carotid stenosis. And finally, self-management and family support is very important for secondary stroke prevention. About stroke prevention guideline is very important. EBM guideline is very important, this issue. But successful implementation is this guideline is depending in some situations, such as having locally developed content or background, or having regional specific barrier and identification of it and solution of them, and have a local socio-economic, socio-cultural condition, and considering on these issues. About this systematic review last year, about guideline last year, systematic review published about this guideline in low and middle income countries by the Bolton World Health Organization. In this systematic review flowchart you see here, more than 4,000 documents searched and analyzed. Finally, based on considering inclusion criteria, finally 108 guidelines from 47 countries considered. You see here about the proportional stroke guidelines satisfying standard. You see here in this figure about analysis of this item. About dark column means low income countries, other one middle income countries, and the light color means high income countries. About transparency of guidelines, the guidelines analyzed, and conflict of interest management, about considering systematic review, about grading of recommendation, about articulation of recommendation, and data of future review. The 108 guideline analyzed showed that there is direct relation with income. If income increases, the guideline is better and considering more this item. But about multidisciplinary developing group and about external review in low income countries, this is better than other countries. About considering a proportional stroke guideline with promoting characteristic for a stroke, you see here again item individually. About translationality, low-income countries situation is better, more guideline consider this part, but about middle-income countries did not consider this item, and in high-income countries it is lower. But about implementation plan in low-income countries is better than others a little bit. About implementation plan in low-income countries, it is better significantly in comparison to other countries. About research recommendation in low-income countries, there is no item, no consideration, but in low-income countries, it is again 50% considered, and in high-income countries, about 40% of guideline considered research recommendation. About economic consideration in low-income countries, no consideration you see here, and about other middle and high-income countries, it is considered lower, about 10%. About social consideration in guideline of low-income countries, it is considered more, about 30%, and others a little bit lower. But about legal and ethical consideration, as you see here, low-income and high-income and middle-income countries didn't consider this legal and ethical consideration, and about high-income countries, this item is again lower. And the other issue about this analysis of guideline, you see here, for the item regarding different components of the stroke guideline, you see here about surveillance, as Dr. Vasey said, there is no good guideline. There is no guideline in this analysis you see here, unfortunately, and we need this work about this item more. About primary prevention, you see here in low-income countries, didn't consider in this analysis, but about primary prevention, about middle-income countries, about 50% of guideline consider this item, and high-income countries about 50%. About secondary prevention, you see here 23% of guideline in low-income countries consider this item, secondary prevention. In middle-income countries, they consider about 50%, and in high-income countries, about 80% of guideline consider these secondary prevention items. About acute care, acute stroke care, in low-income countries, situation is about only 25% of guideline consider about acute care, and in middle-income and high-income countries, it's near together about 80%. And about rehabilitation, again, in low-income countries, didn't consider this item in guideline, but in middle-income countries, about 60, and high-income countries, about 90% consider in this analysis. Other important publication about stroke in low-income countries published again last year by Commonwealth World Stroke Organization and World Health Organization by a commission group, neurology commission group on stroke, with aim of decreasing the global burden of stroke in low and middle income countries. Method of this analysis was by using a questionnaire, WSO comprehensive questionnaire, data gathered from 84 countries regarding pillars of stroke, quadrangle about surveillance, prevention, acute stroke, and rehabilitation. Response rate in this review was very good, about 92%, 34 countries from high-income countries, 23 from upper middle income countries, and 21 from lower middle income countries, and 6 from low income countries participated in this survey, and about 322 health professionals participated from 261 hospitals globally. You see here about the situation about surveillance item, very good situation. You see here about in the West South European countries, you see here green color. Good situation about surveillance, you see here in more of West Europe countries, China, Korea, and Iran, and Sudan, South Africa, and Argentina, and Mexico, you see here. And acceptable situation, you see here in US, in Canada, and most of South America, some parts of Africa, Australia, India, and poor situation in Kazakhstan, and absent data from some South America, here, Afghanistan, in Pakistan, sorry, and no data in many parts of Africa, you see here, and Greenland. About secondary, about stroke prevention, you see here, situation was very good in Thailand, and good situation in most of Europe, you see here, and Iran, and New Zealand, and some part of South America, Mexico, Colombia, acceptable situation in the US and Canada and Australia and China, India, and some part of Africa. Poor situation is more of South Africa, America, and some part of Africa you see here, and absent situation in some part of Africa, and no data again from Africa. Like changing the node. And about acute stroke care, you see here situation very good in Thailand, Iran, and South Korea, South Africa. Good situation in most of Europe, China, Australia, and US. You see here, and Colombia and Chile, and acceptable situation in most of South America, India, Kazakhstan, and some part of West Europe, and a few part of Africa. Poor situation in Canada and some part of Africa, and absent data you see here, and no data again from Africa. And the last one from this article, you see here very good situation in Thailand, again about rehabilitation items, and good situation in some countries from west of Europe and South Africa, Mexico, and Chile. Poor situation again from South America, China, Kazakhstan, India, most some parts of Africa. Again, absent data from Canada, and no data from Africa. But in this article, noticed, data from Canada may not be representative for all country, because a few profession participate in this research, in this survey. Because of that, we don't represent the data in about Canada. In this slide, you see here all these 4 items in one slide. And as you see about our item secondary prevention, the lowest value related to Africa, and it needs more attention. And last article you see here about this situation. As we know, stroke is one of the main non-communicable diseases, and if we consider NCD policy, we can put primary and secondary stroke prevention. About this policy, NCD policy, last year we published a good article in Lancet. You see here about implementation of non-communicable disease in the all member of WHO during the 2015-2020. In this research, they considered NCD policy implementation score about all WHO members in the 5-year, and they analyzed the average number of monitor reports and analyzed based on each country. And based on this research, they developed framework for indicator of national charities of influence policy implementation, about including democracy, corporate situation, NCD burden, and risk factor prevalence. In this slide, you see 19 policy of WHO about NCD burden. This 90 item you see here about national NCD targets, national action plan, physical activity policy, clinical guideline, graphic.
Professor Mehdi Saab, sorry for the interruption. We cannot, your slides are not changing. We can only see figure 2.
Oh, not change, sorry.
Can you reshare the screen? Can you reshare the screen, sir?
You see now the slides?
No, not yet.
Not yet. Sorry, maybe the slide internet is.
You may stop share and can then reshare, please.
Now you see?
No, not yet.
Sorry. Possible changing the slide? I send the slide.
Yeah. Can you stop sharing and reshare again, maybe?
It's not sharing. Okay.
Click the stop sharing button. Can you stop sharing, sir, and then reshare it?
I stopped.
Now you go back to share screen and
Again,
now reshare
share
it, please.
again.
Yes, share it.
Okay, you see?
Yes, yes.
Okay. You see here the 19 policy about NCT. The first one about national NCT targets, other one national action plan, physical activity policy, clinical guideline, graphic warning about mortality data of every country, cardiovascular therapies, smoking, have a smoke-free places, and child food marketing, fat policies, alcohol advertising bans, risk factor surveys in every country, tobacco advertising ban, having this one, alcohol taxes, tobacco mass media, salt policies, tobacco taxes, and breast milk items, and policy about alcohol sale restriction. As you see here, in all countries, you see here about implementation value. Globally, about 33% of countries, 33% of countries fully implement these policies, and about 30% implemented partially. And about globally, implementation was lowest about policy relating to alcohol, tobacco, and unhealthy diet, as you see here. You see here this slide. In this slide, you see individually, the countries individually, the ranking of this scores in 22 situation of NCD policy. I'd like to zoom. As you see here, the first ranks related to countries of Norway, Turkey, Iran, Turkmenistan, Finland, France, China, Costa Rica, Czech Republic, Estonia, Ireland, Kazakhstan, Lithuania, Moldova, Portugal, Slovenia, Thailand, and UK. And other one going to decrease. This is again related to this scoring in all WHO members. And finally, in this slide, you see globally the situation of this NCD policy, as you see here, based on World Bank income country, high income, upper middle income, lower income, and low income country. In this slide, you see coding of this green. It means that better, the situation is better and high value. If color is red, it means that the situation is low. As you see here about high income countries, we have more green colors. About upper middle income countries, it is the green colors going to be lower, and red values again appear. About lower middle income countries, the green item is only 3, and others is low than 50%. About low income countries, we don't have only one green color more than 50%, others is green. It means that situation is bad in low-income countries. About the interpretation of this article, means that implementation of NCT policy is uneven in the world, but broadly improving over time. It can promote a situation, prevention situation in the future. And low-income and less democratic countries have lowest policy implementation. And as a conclusion, based on this discussion, this presentation, it is clear that situation is worse in low and low middle income countries compared to high income countries because of a higher incidence of stroke, more limited access to high quality healthcare, low affordability of medicine, especially in rural places. And therefore, we need urgent action for boosting and help to implement NCT policies, including a stroke guideline to especially to support countries having a good rate indexes. And as I said in a slide, we need more follow-up study about secondary intervention, especially in African parts. Thank you. Thank you for attention.
Thank you very much, Professor Mehdi, for a very informative presentation. As you said, unfortunately, low-income countries had the lowest policy implementation, and an urgent action is needed. We will take questions during our panel discussion, as we are already short of time. For the next presentation, we have one of the leading stroke experts worldwide. He is an excellent teacher, a great researcher, and it is always our pleasure to listen to him. I invite Professor Dr. Ashfaq Shoaib, directly from Canada, and his title of talk is Strategies to Promote Stroke Care in Low and Middle Income Countries.
Assalamu alaikum, and thank you for your kind invitation. Here's my title, and I have no conflicts for this presentation. I also just wanted to share my, this is my house, and it's winter here. And I'm always grateful to my dear friend, Professor Wase, for inviting me, especially when he makes me wake up at 2 in the morning. So it's 2 in the morning here. I have been deleting slides because there's a lot of overlap in our presentations, but I'll try to at least emphasize on some of the points in primary prevention and acute care as it relates to our promotional strategies of how to improve things. So this is what I've summarized from what has been discussed so far. That if you're in a low to middle income country, your risk of dying from a stroke in the year after a person's had a stroke is 56% compared to high income countries. And in fact, in many of the high income countries, this has gone down to less than 15% now. This hovers around 12% for us in Alberta. I also have noticed, and this is data that's been recently published, that if you look at the use of aspirin in secondary prevention, and aspirin is cheap, right? Aspirin costs hardly a rupee or two per day. Its use is less than 4% in low-income countries after somebody suffered a stroke, compared to 28% for middle-income countries and more than 53% for high-income countries. Professor Wase had talked earlier about access to CT scans. So if you look at CT scans per million in low-income countries, it's about 1.3 versus 21 in high-income countries. And the DALIs, as they're called, the lost opportunities, is more than 3 times higher for low-income countries compared to high-income countries. And what really scares me, and it's really important, this is data just recently published from, in fact, last week from Africa, that the number of researchers that create this kind of data and help us improve things is only at 83 per million in Africa compared to over 1,000 in high-income countries. So it's a big problem. I've deleted a few slides that relates to what are the low-income countries, because that was very well explained by the two previous speakers. So this is your problem, and what do we do? So if you look at stroke incidence and prevalence, then what this translates into, I've marked for you, is down here. So in here are multiple countries, and this is from the year 1990 to 2020. For countries of low and middle income, this is more or less flat. It's hardly moved at all. In fact, it's rising, both for incidence, which is the number of cases, new cases per year, versus the prevalence, which is the number of cases at any given time in the country. And you compare this to high-income countries, and you can see the graph. This is no rocket science, right? I just added the red lines. So significant decrease in age-adjusted rates for incidence as well as prevalence. If you put more resources, you will see these kind of results. That's the background, and this is what I want to talk about. I wanted to initially talk about the essential components of a stroke program. We've dealt a lot about primary and secondary prevention. They are important, and acute stroke. And then, towards the end of my presentation, what can we do to improve things in low to middle income countries? So this is what I feel is a important parts of a comprehensive stroke program. These are all the components that we have in our program. And years ago, I was about 5-6 years ago, I was in Qatar, and we implemented more or less all these. And so you can do it. It just requires resources. I believe, and this is how it works here. So take the example of my city. It's a city of about 1 million people. There are 5 large hospitals, and we've designated 2 of these as our stroke hospitals. And part of the reason is that you don't need to duplicate resources, because some of them are very expensive. So thrombectomy, for example, we have one hospital in our city and another one in Calgary in the province of Alberta. And the size of Alberta is the size of France. So it's very huge, but you can get these patients to these tertiary care centers because the resources are expensive. And this is no rocket science. You need a lot of these individuals. You need nurses, occupational therapists, physiotherapists, etc. And for today's discussion, what really breaks my heart in places like Pakistan and many of the underdeveloped countries is that we do not have enough stroke prevention, stroke units, more than stroke prevention. I graduated from Peshawar in 1980, and recently in the last a few weeks, I've been talking to some of my very junior colleagues, and it just dismays me that when I left in 1980 and 2 weeks ago, when it comes to stroke care, really nothing has changed. There are 4 medical units at the Khyber Hospital, and there's 4 at the Lady Reading Hospital. And it's not I'm not being critical. I just feel that change has not happened. Every day, each ward, so every day there's one ward that admits patients. So for instance, if it's Monday, the medical A would admit patients. So anything that comes to the hospital, whether it's a stroke or a GI bleed or somebody with tuberculosis, they all get admitted. These wards usually have 40 to 60 beds. These patients get admitted all over the ward. So there's no specialized unit, which I think is one of the most easiest things to do, but they're lacking. So, I mean, I think when you talk about policies, they have to change. We focus on thrombolysis and thrombectomies. These are icing. These are the icing on the cake. The more important thing is having a stroke unit. We've almost no rehab in many of these facilities, as has been shown by my previous two speakers. And we put a lot of emphasis on imaging. You know, most of the times, if you're not going to give TPA, and if you're not going to offer other interventions, its imaging is important, but it's not essential. Whereas stroke units are essential. And of course, education is very important. And I believe very strongly that unless you have data, you can't go to your ministries of finance, etc., to make your case. So that's very important. This was shown earlier by my really good colleague and friend from Iran. The only reason I wanted to show you this data in the recent survey is that and I'm trying to make a case for stroke units. There are 91% of high-income countries would admit their patients to a stroke unit compared to 18%. To give you an example, in Pakistan, my understanding is that there's 10 stroke units, and unfortunately, most of them are in private hospitals, not accessible to the vast majority of patients. So it is a problem, right? It's a big problem. So that was my understanding of how a comprehensive stroke program should be. This is the reality on the ground, and so if you look, take these things in consideration. Most of our focus, as obvious from my previous two colleagues, is on prevention. So prevention, we've discussed primary prevention, secondary prevention. I will not spend too much time here. I just want to make a couple of points as I move along. We all believe, and I'm sure you'll all agree, these are old quotes. The care of a patient who suffered a stroke would never be the same as somebody in whom the stroke can be prevented. I mean, so this is the rationale, right? Another important rationale that I'm sure all of you would agree on is that it's better to be alive than ill or dead, right? And this is the beginning and the end of the only real argument for prevention. So prevention is very, very important. We've all looked at this data. Now we talk about inactivity and obesity. I actually am 65 years old now. I get on the elliptical for 30 minutes at least 3 times a week, and it's not fun, but we have to do it. We've talked about some of these risk factors. I believe I'm going to spend a little bit more time on the dietary risk factors because you can manage these. We've talked about smoking and hyperlipidemia and hypertension. So these are all very, very important risk factors. What is emerging, what's really important in this era of climate change is pollution. And so many of these are individual, right? So you can actually exercise and decrease your risk. You can cut down on salt, and you can, cut down on your weight, I suppose, and decrease diabetes. But this is global. I mean, you can't change the environment in Lahore. I mean, Lahore is considered to be one of the dirtiest cities when it comes to pollution worldwide. I'm really sorry for anyone who's listening in from Lahore, but that's the reality, right? And these two are related. Diet and eating habits and gut microflora, they're very, very interesting as emerging risk factors. So if you're careful, so you eat more vegetables and you exercise, you can improve your gut flora. And what that does is that it improves your pre-diabetic or insulin resistance. It cuts down on chronic inflammation. It also improves your risk of diabetes. So all of these are important. And for our work, our more recent work is on vitamin D. We look at low vitamin D as a major risk factor for atherosclerosis. So get out in the sun, I suppose. You get to see a lot of it. I don't see much of it here in Alberta these days. I just want to touch on these because for policy, it's going to be very important access to clean air, making sure that you eat more vegetables and exercise, right? So this is just something that got published from Canada here in 2 weeks ago. Actually, it's in the International Journal of Stroke. And I just wanted to make 2 quick points. As we grow older, you can see as we grow older, our risk of most of these vascular conditions increase, right? We can't change that. This is just life. But on the other hand, what you can change is your habits, right? So improving in obesity over time as you age, and smoking is almost virtually disappearing in Canada. So these are the kind of risk factors that you want to focus on. Why these are important is to how soon in life do you get these risk factors? And if there are multiple risk factors, they're very cumulative. So here's 2 examples. If somebody gets multiple risk factors, so if you've got 3 to 4 risk factors, and they come on early in life, see, under the age of 40, and this is what Dr. Vase talked about in Pakistan also, look at the cumulative risk over time. Over 15 years, if you're young, and if you have multiple risk factors, your risk of stroke goes up very high compared to somebody who's 50 years old or 60 years old when they develop their risk factors, right? So prevention starts early. Most of these things are individual, but unfortunately with the global warming and climate change and pollution, you will see them more earlier, and unfortunately many of these you may not be able to control also. I wanted to share something from Pakistan. This is a very good piece of research that came out mostly from Aga Khan University in Karachi. It's about 2013 in Lancet, that looks at multiple risk factors. So it looks at cardiovascular disease and chronic respiratory diseases and cancers, and you can see that tobacco use and hypertension are important. And this is 2000, and then here's 2025, and it will increase much more over time. So what are the basic risk factors? I think Dr. Vase touched on it. Here's tobacco use, very preventable. Hypertension is what I was talking about, which is food, and these are kind of related together, obesity and lack of physical activity. So if you had a reduction, I mean, can you make a difference, right? So here's what I wanted to show you. If you reduce your tobacco intake or hypertension treatment, or improve your glucose, this is how big a difference it makes. So here's a 30% reduction in tobacco use. Here's hypertension, just treatment by 3 millimeters, and improving glucose. So see how big a difference you make. And this is where policies and education and efforts at communication becomes important. On the huge stroke side, when somebody, and many of our colleagues today who are listening in are not physicians, I just quickly made the slide for you that when somebody comes to the hospital, this is what you do. You first stabilize the patient, because their deficit may progress if you don't stabilize them. You make your diagnosis, you make sure it's a stroke. And then in many of our centers, we want to make sure they're candidates for TPA or thrombectomy. You decide on a diagnosis, and you make preventive strategies that we've talked about. So what have we done, right? So in our developing low-income countries, it's only 2 things that are required. You stabilize the patient and you move them to a stroke unit. What is a stroke unit and why are they so important? So in here, the reason why we say we stabilize them and move them quickly is that they stay in the emergency department. The emergency department is not a very good place to take care of stroke patients. One of my colleagues from Qatar published this data. If these patients stay longer than 8 hours, you can see their risk of complications increases. Their risk of complication more or less doubles. And what this translates into is their outcome. So this is data published a few years ago, that if they stay longer in hospital, their outcome, which is defined as a modified Rankin scale, So here's less than 8 hours, and here's more than 8 hours. You can see that there's an absolute difference of more than 4% in patients who are just staying longer in the emergency department. If these patients go to the stroke units save lives. So here's the data. Here's data from China, from India, from South America, Africa, and Europe. In all of these, if the patient goes to the stroke unit, they do better. And how better do they do? Let's compare it to TPA. So if you had 1,000 patients in a population, you assumed that 750 of those were admitted to the hospital because others are milder and they may not come to the hospital. If you were to have 70% of these patients admitted to a stroke unit, you would avoid 33 patients with additional death and disability. And if 80% of them got aspirin, an additional 8% of these patients would also avoid death and disability simply by just putting these patients in a unit. There's a lot of fuss about TPA. I know data from the low to middle income countries that only 2% of patients get treated. And this will only prevent one additional disability. So clearly, much more benefits of putting these patients in stroke units. And I'll urge you to focus on these units as one of your priorities, as was earlier mentioned also. Here's data from Qatar. We published this a few years ago, that by making a stroke unit, not only do you prevent disability, you decrease the length of stay of these patients from 14 days to on average of 8 days, and you decrease the complications from 23% to 6.4%. So stroke units is my very important message for you today. And just to show you the data, this is just got published last week. It's a really important paper. It looks at this in the low to middle income countries. What are the various facilities available? So here is in blue countries, 5 countries here, where you can do thrombectomies and thrombolysis: Algeria, Egypt, Nigeria, Kenya, and South Africa. And then stroke units, right? So stroke units are available in these countries. Most of these countries that have thrombolysis have stroke units. But unfortunately, in the rest of the African continent, none of these things are available. So your focus should not be on high-end thrombectomy. I mean, those are important too, if you can have access to them. But more importantly, you need to have stroke units, because this is where a huge difference is going to occur in your outcomes. So what can we do? And I'm going to end my presentations here. I have my dear friend online just now. He's one of your panelists, Dr. Osama Mansour. He has done a lot of work and with colleagues in Pakistan and Iran and across the Middle East, which is a MENA-SINA Alliance, really important organization that's trying to encourage primary prevention, secondary prevention. And these are the kind of alliances that we need. Registries are important. And if you go to the WHO site, you can actually pick up registries free of cost, and they're very simple. I want to talk a little bit about the program in Iran, not because Mahdi is here, and he's a friend, but I also want to show you there, once a country puts things together. So a few years ago, I got involved with them and helped with their national acute stroke program. This is very, very interesting. They've just recently published their data here. And this campaign involved public awareness, training of personnel, developing stroke units, a national registry for TPA. They were doing less than 50 TPAs for years, but when the national program was implemented, and Mehdi can certainly talk about this in his as a panelist, but their numbers increased to more than 2,000 to 3,000 treatments across the country. They would have annual meetings. There was excellent inter-hospital coordination. So it can be done. I mean, the resources that we put in place, but it can be done. So national programs are important. What we can do in our countries is, we can promote healthy diet. This doesn't cost too much. In fact, fortunately, at least from the time I was in Pakistan, your vegetarian diet is much more cheaper, right? There's nothing wrong in improving physical activities, and you've got to worry about access to clean air. We've talked about vascular risk factors, and they're really important because prevention is the key. And finally, developing of stroke units, right? So just two quick examples, and then I'll end my presentation. And I'm giving you these examples because it can be done. Here's something that was published 2 years ago in the New England Medical Journal. It's like Science or Nature for physicians, and it was from Bangladesh. They showed you that if you have aggressive intervention, you can actually improve care significantly, decrease the blood pressure, systolic and diastolic in the intervention group. So, excellent data coming out of low to middle income countries. And then there is this issue of polypill. Iran just did a study on it. There's a study from India that the advantage of a polypill is that it improves compliance. It's a pill that contains aspirin, cholesterol-lowering medication, and blood pressure medication. So I think Wasi and I've talked about this, that in a place like Pakistan, if you're going to put your resources into good pharmacy, you've got to go for polypill. Here's something else that got published 2 days ago, which talks about how do you manage acute stroke in resource-limited countries. And I just gleamed this out. So their most important messages: stroke units where you can avoid aspiration, infection, bed sores, or DVT. So it's all about prevention. My final slide, and this is very close, dear to me, is TPA is expensive. And can we have better alternates? I've been trying for years to promote streptokinase, which I believe is very safe and just needs to be tested. But here's some colleagues from Russia who looked at staphylokinase. And so they actually did a study comparing staphylokinase. I've got the reference right here. And I've been trying very hard to find out the supplier for staphylokinase. That they compared it to streptokinase, and they in fact show that it's very similar. His outcomes are very similar when you look at modified Rankin scale with staphylokinase versus TPA. So here's my challenge to you in COMSTECH, my friends. Get this drug, find this drug, and it's hopefully going to be much more cheaper than TPA. TPA is more than $1,200 in Pakistan. So my final slide is right here. Stroke is a major problem. It's a bigger problem in the low to middle income countries, as has been discussed. And there's very urgent need to improve awareness in the community and improve lifestyles and manage risk factors. You've got to make it a high priority. I think I could hear it in the plea that Professor Wasi was making. You've got to make it a higher priority than we have it currently. And if there's any message that I can leave you, my friends, is to build stroke units. They're cheaper, they don't cost you much. It's just one designated area of your hospital. You're admitting those patients anyways, and you just have to prevent complications in them. And that's it. I thank you for your attention, and look forward to your panel discussions. Thank you for your attention.
Thank you very much, Professor Dr. Ashfa Shweta, for this enlightening talk and stand late for us. As always, it was a pleasure to hear you, and your emphasis about importance of stroke unit is well taken. Thank you, sir.
Very
For the
welcome.
next talk, I will invite Maria Khan. She works at the Rashid Hospital, Dubai. She has a long affiliation with Pakistan. She got her medical education as well as postgraduate training from Aga Khan University, and she is always available to promote stroke awareness. Her title of talk is Stroke in Women.
Okay, Assalamu alaikum. Can you hear me?
Yes, we can hear you.
Okay, fantastic. Thank you so much for this opportunity. It actually allowed me to look into this very interesting aspect of stroke, which I think is overlooked all the time. And it was good to review some of the recent data that has come out on stroke in women, which I will be sharing with you. I don't have any disclosures for my talk today. So this is a brief outline. We'll talk a little bit, so there are two paradigms here. There is one paradigm where we are talking about how is stroke different from in low middle income countries compared to high income countries. And then the other paradigm is how are women differently affected in these countries. To be very honest, there is hardly any data which is geared towards looking at women coming out of these low middle income countries. There is, of course, patchy data that's available looking at causes of strokes, and I will be sharing some of that data with you. So we'll talk a little bit about these two different angles to stroke epidemiology. And then I'll talk about the stroke risk factors in women. I think very importantly, the sensitization is important. And I feel that even us as stroke neurologists do not have enough sensitization to stroke risk factors that are specific to women, that are sex specific. And I think more research needs to go into it, and more awareness needs to be created amongst the people who will manage these women eventually. And then I'll talk a little bit about stroke treatment and outcomes in women and how it differs from men. So the lifetime stroke risk. So just starting off with comparing how the high income compares with the low income. And I think enough has been said already. I'll just recap a little bit of it. The global lifetime risk of stroke from the age of 25 years was about 24.9%. And there were important between country differences that were seen in this data. The low socio-demographic income countries had the lowest risk. This is a good news for us, that the lower your socio-demographic index, the lower your risk of stroke. This is at least what the data is suggesting. However, we must understand that a lot of this data is coming from substandard studies, where we don't think enough data exists, where we don't think the data is effectively captured. So with what we have available, this is what it looks like. And the middle income countries, they had a higher risk, about 29.3%. In South Asia, the lifetime risk of stroke was 15%. And another important aspect in this is an element of competing risks, which means that you have other risk factors that lead to an early death from other causes, so that your population doesn't reach that stage where they can have, for example, a stroke. So you would notice that a lot of times because of maternal mortality in certain countries, low-income countries, women may not be reaching the age where they are more likely to have strokes. So all of these are factors that play in when we look at these numbers. This is the GBD study that was published in 2018. The data is from 2016. And this showed that Asian countries constitute about 66% of world population and almost 70% of global stroke burden. And among these Asian countries, the South Asian countries, which are about 22% of world population, are the ones that are hit the hardest. And they obviously contribute greatly to stroke mortality, and about 40% of global stroke deaths are occurring here in these countries. Now, how does that data differ in terms of women? Again, you would tend, if you look at this, this is again from the same study published in 2018, where they looked at the lifetime risk, and they showed that the low-income countries, so if you look at the sub-Saharan Africa, if you look at India and Pakistan, if you look at a lot of these South American countries, which are most of them low-income countries, their lifetime risk tends to be low. And then I already alluded to some of the factors that are responsible for these figures that we are seeing. So I don't think we should be too happy about this comparison that is being made, but we need to understand the reasons behind these low rates that we are seeing. If they're truly low, I'm happy, but I don't think that is the case. Now, how is the stroke incidence and mortality in women different? So worldwide, and unfortunately, we don't have a lot of local low-income country data, but worldwide, stroke incidence, prevalence, and mortality are higher in men than women, particularly in the developing countries, except in the Middle East and the North Africa, where the data seems to suggest that the women have a higher stroke mortality. Also, recent data from high-income countries is suggesting that we cannot generalize this statement across all ages, and at older ages, women, beyond 75 years of age, which a lot of women from low-income countries would not even reach, there would be a higher incidence of stroke in this age group compared to men. Alternatively, in Southeast Asian countries, data has shown that below 40 years of age, women have an increasing risk of ischemic stroke. And the figures that have been quoted comparing the 1990 and the 2015 figures in the GBD study show an alarming increase from 0.5% to 11.4%. So, of course, across all age groups, you cannot generalize that women are more protected compared to men. Women in higher age groups tend to be affected more. And at least from certain Southeast Asian countries, we know that the incidence in women is on the rise. Now, I'll next come to the stroke risk factors. And I think enough again has been said about these. This is the GBD study 2019. And what I've circled here are the main risk factors that tend to affect the low middle income countries. Air pollution is on the rise. It is tending to affect the low and middle income countries more compared to the high income countries. The environmental risks, which include factors other than air pollution as well, are also on the rise, with 48.6% DALYs being contributed by low-income countries. And metabolic risk factors, of course, which includes diabetes and hypertension and obesity, and those are also, and dietary factors also can lead to a significant amount of DALYs being contributed to stroke risk factors. Now, this is for both genders, not particular to women. And again, here, this is a depiction of the same thing, where high systolic blood pressure and particulate matter pollution, high BMIs, high fasting plasma, and smoking, all of these are the most significant factors for all stroke subtypes. Now, what about women? So let's be a little more specific on how factors differ. And here you will see three kinds of risk factors. One that are sex-specific and found, of course, exclusively in women. Then there are risk factors that we have data to believe that they are stronger and more prevalent in women. And then a third group where we are not sure whether a difference exists, or we are not sure even if a difference exists in the prevalence of those risk factors, whether it has a true impact on causing more strokes. So starting with sex-specific risk factors, and I will come individually to some of these risk factors in my subsequent slides. So pregnancy, preeclampsia, gestational diabetes, oral contraceptive pills, postmenopausal hormone use, and changes in hormonal status have all been identified as risk factors for stroke in women. Then there are factors that we know are more frequent in women, more prevalent in women, and they are stronger risk factors for women compared to men. And amongst them are migraine with aura, atrial fibrillation, diabetes, and hypertension, which is rather surprising because, atrial fibrillation, diabetes, and hypertension tend to be risk factors for men as well, but the association with stroke is much higher in women compared to men. And then, of course, there are psychological factors like depression and psychosocial stress that has been very well studied in the interstroke study as well, which is more prevalent in women and which is found to have a stronger association in women to stroke. And then you have risk factors that are maybe similar in prevalence amongst men and women, and we do not know whether there's a difference in the impact they're having on each gender. And amongst them are physical inactivity. Gender, we now know with some recent publications that age is a big factor. At higher ages, women are affected more. And then prior cardiovascular disease, obesity, diet, smoking, and metabolic syndrome. So this is a sort of a summary of, excuse me, of all the risk factors that are there, and which ones are more frequent or more prevalent in women and which have a higher association. Okay, now, just this slide basically repeats the sex differences in conventional vascular risk factors. And here you can see that hypertension, although the prevalence tends to be lower in women compared to men, in the younger age groups, the prevalence is higher in older age groups. And the association with ischemic stroke is similar in women in younger age groups, and it is higher in older age groups. Similarly, for dyslipidemia, the data is conflicting. Either we think that the prevalence is similar, but the association with ischemic stroke seems to be weaker compared to men. Atrial fibrillation, on the other hand, is much more prevalent in women. Of course, this again is age dependent, but it is much more prevalent in women, and the association with ischemic stroke is also much higher. Migraine is also higher in women. The association with ischemic strokes is also higher. The prevalence of diabetes tends to be equally distributed, but the association of diabetes with ischemic stroke is much higher in women. So you're beginning to get an idea of how these risk factors may be more prevalent in women, or sometimes even if they're not more prevalent, their association with stroke seems to be much higher. And when we are managing women, particularly for secondary stroke prevention, because often, I mean, unfortunately in low income countries, primary prevention is not something that is given a lot of focus, but that is the real area where you need to focus, because a woman with diabetes is at a higher risk of stroke compared to a man with diabetes. So those are important differences to keep in mind. And then I will come to sex specific risk factors. So starting with pregnancy and puerperium. Although strokes in pregnancy are uncommon, pregnant and postpartum women are 3 times at higher risk of stroke than other young adults. And there was a systematic review in 2017, which did an analysis of 11 studies, and they found the crude incidence rate of 30 per 100,000 pregnancies. And they also found that the incidence varied according to the timing of within the peripartum or the puerperial period, and the puerperium tends to be the highest risk period for strokes. I will just, I don't have a separate slide for this, but cerebral venous thrombosis is a kind of stroke, again, a rarer kind of stroke compared to the other strokes combined, but that also has a huge female preponderance, particularly in these low middle income countries. And the peripartum and the postpartum period is the highest risk period for these women. And then there are other factors that lead to stroke in pregnancy. So for example, you have strokes can happen because the women have antiphospholipid antibody syndrome. They may have atrial fibrillation. They can have cardioembolism, congenital heart defects. All of these could be pre-existent, and the state of pregnancy can worsen these risk factors. And the reason for that is that pregnancy is a high flow state. So a lot of times cerebral aneurysms can rupture because of it. Cardioembolic events can happen in unstable cardiac diseases. It's a hypercoagulable state, so that can lead to a stroke in pregnant women as well. So it's not one risk factor. The pregnancy overall can have a number of other risk factors that are putting a woman at risk of developing strokes, be it ischemic or hemorrhagic. And then, of course, a very important aspect is hypertensive disorder of pregnancy. And I think this is a very important area of education, particularly for our obstetric colleagues, because they need to understand that the implications of preeclampsia and eclampsia are not restricted to within the pregnancy itself. And I will show you some recent data to make that point more clear. So hypertensive disorders of pregnancy, as we all know, include preeclampsia, eclampsia, gestational hypertension, and a number of underlying vasculopathies are also there, such as reversible cerebral vasoconstriction and PRES. These have been shown time and again to have an increase in prevalence over time, and they confer a more than 5-fold increase in the risk of stroke compared to women who do not have a hypertensive disorder of pregnancy. And this risk has been shown in a number of studies, and this is one of the papers that has sort of summarized a lot of factors, adverse pregnancy events on future stroke risks. And some of these women have been followed up for 40 years to see how, for example, gestational hypertension can lead to an increased risk of stroke at a later point in their life. Similarly, preterm birth can do the same. And even mild preeclampsia has a higher risk, and severe preeclampsia, of course, has an even higher risk. Okay, then this is a recent paper that I think came out last month on the association of preeclampsia with incident stroke in later life among women in the Framingham heart study. So this was the Framingham cohort, and what they looked at was women who had a history of preeclampsia. They, of course, evaluated the other factors that are time-varying factors like the age of the patient, the blood glucose, lipids, weight, hypertension, all those other risk factors. They looked at medical factors at baseline like smoking, weight, hypertension, and they looked at socio-demographic factors, risk factor for future stroke. There were about 1,435 women who with and without a history of preeclampsia. And after adjustment for age and time varying vascular risk factors, women with a history of preeclampsia had a more than 3-fold higher risk of experiencing a stroke in later life compared to women who did not have a history of preeclampsia. So this is a very important area of intervention for low-income countries like ours, where access to treatment is also poor. You know, this is where you can prevent, you know, your high-risk group, where you need to address other risk factors in order to prevent strokes from happening. Then there is hormonal contraception. The risk of ischemic stroke is estimated to be about 2 times higher in those women who use estrogen-containing oral contraceptives than in non-users. Again, this risk depends on the dose of estradiol that is contained within the pill. And 2015 Cochrane confirmed this higher risk. It found 1.7 times greater risk of stroke and a similar magnitude of increased risk with increasing doses of estrogen. Then menopause is another very important area where a woman is at risk. So age of onset of menopause is an important potential sex-specific risk factor for cardiovascular disease and stroke later in life. So there are 2 important studies I want to quote here. One is the Nurses' Health Study, which found that age at menopause younger than 40 years is associated with a higher risk of total stroke. Now, for the women that we are looking at and evaluating for stroke risks, this is an important risk that we should sort of keep in mind when we are evaluating. And then in a recent prospective cohort study compared to women who experienced menopause between 50 and 55 years, those who had a menopause before the age of 40 were at 1.48 times higher risk of stroke. So again, menopause, an early menopause puts a woman at a higher risk. And then there's another concept of reproductive lifespan. So it's not just an early menopause, but it's the total number of reproductive years that a woman has. So for example, somebody has an early menarche and an early menopause, or a late menarche and an early menopause. For example, a late menarche and an early menopause would reduce the reproductive lifespan of a woman. And this particular study found that a shorter RLS of 34 years or or less was associated with a higher risk of incident stroke compared to a medium reproductive lifespan. So again, this has to do with endogenous estrogen and the exposure to endogenous estrogen. So these are things that we must keep in mind when we are evaluating women, which gives us an idea of how much higher their risk is. Then there is postmenopausal hormone replacement therapy. The present understanding is that late introduction of HRT increases the risk of thromboembolic events, whereas early introduction confers little to no risk. Transdermal estrogen, we know, is safer, but its use is still not as rampant as we would want it to be. And generally speaking, HRT should be avoided in women who are beyond 10 years from their menopause, or who have other risk factors that are putting them at cardiovascular disease risk. So again, we need to keep in mind that it's a fine balance that needs to be created between provision of estrogen and withholding it after a certain number of years after menopause. So this is a summary of the female-specific stroke risk factors that I just talked about. Early age at menarche, we know for sure increases the risk. Early age at menopause, we've seen increases the risk, and less than 40 years is a much more studied age cutoff for this. I showed you recent data about reproductive lifespan that's coming from a prospective cohort. This table is an older table. I think we have good data to suggest that reproductive lifespan is an important risk factor. Then low estrogen has a risk association that has been shown. Then exogenous hormones, oral estrogens, we know increase the risk. Combined OCs increase the risk. Progesterone-only contraceptives is an area where we don't have evidence that it increases the risk. And of course, we need further research to substantiate this claim. Similarly, the transgender exogenous estrogens or exogenous testosterones that sometimes, exogenous estrogens we know increase the risk, testosterone we are not sure. So these have also been studied, and of course more research needs to go into this. And then we have clear evidence that pregnancy-related exposures like pregnancy and the puerperal period and gestational diabetes and hypertension all increase a woman's risk of having a stroke later in life. Now, just a few more slides on how do the presentations in women differ from men. So women are more likely to present with non-traditional stroke symptoms compared to men. So as neurologists or as clinicians taking care of women with stroke, we must realize that women they may have all the classic, the face, arm, speech, vision, balance issues that men have, but they're more likely to have non-specific symptoms like fatigue or feeling weak all over or lightheadedness. So they're not really able to describe very well what they're experiencing. And they can just describe it as a funny feeling. They may have impaired or loss of consciousness. And it sometimes becomes difficult to sort of classify that as a focal sign. And hence, many times it's been seen that these kind of symptoms are missed. In addition, women are more likely to present with stroke mimics, including complicated migraines, seizures, neoplasms, metabolic disturbances. And of course, functional neurological disorders tend to be more common in women as well. Meta-analysis reported that female sex predicted a higher risk of non-organic stroke mimics. So we have to keep, of course, this thing also in mind. So on one hand, we may end up missing, what we call chameleons in stroke. We might consider a symptom as a non-stroke symptom, and it is a stroke symptom. And on the other hand, we have to deal with a battery of functional symptoms, for example, that are really truly mimics and not strokes. So the diagnostic challenge is just a little bit more in women compared to men. What about treatment and outcomes? Now, in the acute stroke settings, women, and this is data, of course, that's coming out of the West, because we don't have this sort of data coming out for men, much less women. In the low middle income countries, unfortunately. In the acute stroke settings, women tend to have longer times from arrival to aging. And one of the reasons could be that their symptoms tend to be vague. Certain other studies suggest women are less likely to receive diagnostic investigations and acute treatment compared to men. Another reason could be that they tend to present at an older age and the less traditional presentations are there. And so they're not immediately recognized and there are delays in management. And then, of course, in countries like ours, there is access to secondary prevention is also worse for women. And that has to do a lot with the socio-demographic variables that are existent in our societies. Now, do women respond differently to thrombolysis? There is a recent German study that showed that there was no sex difference with respect to treatment with IV-TPA, and the outcomes at discharge tend to be better in women. But pooled data analysis from Asian countries, stroke registries, suggested that women had poorer prognosis than men after receiving RTPA for acute ischemic stroke, which worsened with age. So again, this data is coming from countries where RTPA is available, and they are one of the more affluent countries, not truly low middle income countries. So you know, but it gives you an idea how that women might be behaving a bit differently compared to women, maybe in the Caucasian population. They also have been consistently reported to have worse outcomes after stroke than men, TPA or no TPA. This may be because of an older age at presentation, worse pre-stroke functional status, and multiple comorbidities that they have. And then the sex differences regarding access to rehab, we all know they haven't really been studied in our countries, but we know that they would exist if they were to be studied. And they, of course, have a significant impact on long-term outcomes. Now, this is a slide that I just put together, you know, intuitively, because I mean, the topic requires work in all of these social determinants of health for women. We know that in low-income countries, particularly, I'll speak from my own experience from Pakistan, India, lower levels of education are there for women compared to men. Their societal roles do not allow them to have, you know, what the West likes to call the me time, where they can focus on their own selves, their own health, and get the kind of attention that they should get in terms of their risk factors. They have higher pregnancy-related complications, and we have a number of studies coming out of our region where we have shown that, you know, CVT seems to be quite common. There is in stroke in Asian women. That data has been published, and they have a number of risk factors that remain quite uncontrolled. Then nutritional factors, again, at the heart of which are social determinants. Women tend to have worse nutrition in low-income countries compared to men. Their access to medical care is worse. Their lifestyles tend to be much more sedentary in at least the urban areas. The rural areas, still women may be very active, but in urban areas, the lifestyles are becoming more and more sedentary. And then, of course, there are still countries where household air pollution is a huge issue, and the most exposed to this household air pollution because of the kind of fuel that's being used for cooking and heating homes. The main victim continue to be women. So these are some very deep-rooted sort of factors that would require a lot of work, you know, to better understand, and then of course to address, and they need to be nipped in the bud. So I'll come to my conclusion slides. Incidence of stroke varies with age. We know that from the Western data, and it may be higher in women than in men in the older age group. In certain Southeast Asian countries, we know that women below 40 have shown an increase in incidence, and we need to be more vigilant about this rise, which seems to be quite alarming, that at such a young age, these risk factors need to be better delineated. We know that there are sex-specific additional risk factors in women, and we must be aware when we are evaluating our stroke, our women for stroke risk factors. And these include the reproductive, these include pregnancy and oral contraceptives and hypertensive disorders of pregnancy. We need to ascertain what the pregnancy outcomes were like, because data now shows that they have a bearing on the future risk of stroke. Reproductive lifespan is an important concept that we need to bring in to be more conscious of it. Women tend to present with more atypical stroke symptoms, so we need to be aware of that and to avoid treatment delays because of this atypical presentation. And then, of course, their outcomes, there is some information that the outcomes tend to be worse compared to men. And we've seen that stroke mortality from the MENA region, at least, has been reported to be higher in women. So the factors need to be understood and addressed. And of course, we know that in low and middle income countries, access to secondary prevention and to rehab is much worse for women amongst other facilities, unfortunately. So thank you for your patience. I will end.
Thank you very much, Dr. Maria Tran. You are right, the sets of specific risk factors as well as where clinical presentations of a stroke are usually missed. And this is something to look for in future carefully. So we will go for the panel discussion. Now for panel discussion, we have three experts from Pakistan. We have Dr. Anjum Farooq, the President Pakistan Stroke Society. We have Professor Dr. Abdul Malik Saab from Liaquat University of Medicine and Dentistry, Karachi. And we have Dr. Hasnain Hashim from Fauzi Foundation Hospital, Rawalpindi. We also have two international experts, Professor Osama Yassin from Egypt and Professor Mehdi Faroudi from Iran. So I will take the questions from the chat box as well, as much as I can, as much as the time allows us. But first, I would like to ask the main point which was highlighted by Dr. Professor Ashfash Repsa about the lack of stroke units in lower income countries, including Pakistan. Unfortunately, we do not have much stroke units in the public sector. We have no stroke unit in any public hospital in Sindh. The same goes for Balochistan. So I would like to ask from Dr. Anjum Farooq, the president of the Pakistan Stroke Society, how to solve this problem and what steps are being taken. Unmute. Please unmute yourself.
Thank you, Dr. Sajid. Thank you so much for invitation. Yes, this is actually a ground reality that in throughout Pakistan, we have approximately 10 stroke units and only 6 centers are offering thrombolysis and they have thrombectomy and very few patients, they are receiving all these things. So Pakistan Stroke Society is working very closely with other societies as well, and we are trying to improve the number of stroke units. We are trying to organize the trainings for general neurologists, for general practitioners as well. So we are working on it, and inshallah, at the end of 2022, we have a plan of establishing 10 more stroke units in different areas of Pakistan.
Okay, thank you very much. Now I'd like to ask from Professor Mehdi Faroudi sir that there is a question in the chat box that recently an increased stroke rate is seen in children and young adults. So what are the main reasons behind it and how it can be avoided?
Sorry, please repeat. Sorry.
There's a question that nowadays an increased incidence of a stroke is seen in children as well as young adults. So what are the reasons and how it can be prevented?
I think, thank you for the question. I think the main issue about prevention of a stroke in young children, maybe lifestyle. Unfortunately, the lifestyle in countries is changing. More activity, I think we need changing in our activity. Unfortunately, physical activity is going to be lower, especially in the corona situation, and due to technology, using mobile or other things. Unfortunately, due to technology, physical activity is decreases. Changing of lifestyle, I think, is very important about physical activity, and nutrition is very important. We should change the nutrition and considering more using vegetable and fruit and decreasing the salt and fat. Based on the policy, I said I think the NCD policy of World Health Organization is very important. They said in this part, I think, explain more.
Okay. Thank you, Professor Mehdi. If there are any questions from the physical audience which are present here, we will be happy to take. Yes, please.
About stroke unit establishment, I should make a comment.
Go ahead, Mehdi.
Okay.
Yes, please. Yes.
Yes, I think in our country, national stroke program is established since about 6 years ago. After some pilot activities in our countries, especially in our university in Tabriz, I think after this involving Iranian Stroke Association and hard activity of this association and involving the Ministry of Health, our program nationalized, and this made a good progress in our country. In 2060, we have about 55 stroke units, but now we have more than 110 stroke units. I think involving our national organization, especially Ministry of Health, is very important. We change only software and organize our situation in hospital and define a code, as Professor Shoaib said, as a 724 hospitals, define this hospital situation, and hospitals applied for going to this program, and it is going to progress. And EMS educated nationally and involved in the program, and it is the main advances that we have by involving all organizations in our country. Other thing is, I think it is registry is very important. If we have a registry, as you know, you are very active in registry of CVT. It is very important if we have a good registry in stroke in units, we can follow our situation and progress situation in the future. Thank you.
Thank you, Professor Mehdi. So we have a physical question here. Yes, please introduce yourself and ask the question.
Yes, Assalamu alaikum. I am Asadullah Faiz, doing PhD in pharmacology from ICCBS. My question is from all of the audience and respected Dr. Abdul Wase. Sir, we are talking about the low income or middle income countries. That means we are talking about the poverty. Poverty is a basic illness of all the diseases. Sir, how can a poor man get a quality food? First question. And as you know, in Pakistan and other middle countries, we don't have a quality food, especially oil. Have you done any conversation with the government to provide a quality food? Or food safety programs have been arranged to prevent the stroke? Sir.
Now, this is very important aspect, that what can be done in low income countries to prevent stroke. I'll tell you things which are very important. For example, in Pakistan. Pakistan is a low income country, low middle income country. Like in Pakistan, people spend 400 billion rupees every year to buy cigarettes. So that's kind of an extra cost. And we are not talking about gutka and tobacco, that extra 100 billion rupees. So stroke care is not expensive. You have to avoid smoking, that's one thing. There's no expense on avoid smoking. It's free if you don't want to smoke. Number two, quality food is not oils and fried food. Quality food is vegetables. If you can eat vegetables, that's the quality food you need. So at this point, In Pakistan, a low-income country, 25% population is obese. They are not obese because not of the quality food, but they are eating poor quality food. So what a lot of people think that there's a very high quality food, like fried food, KFCs, burgers, pizza. They are not high quality food. They are very expensive, but they are not high quality. The high quality food is fruits and vegetables, fruit with low fat and those kind of things. The second thing which WHO has says is very important for stroke prevention is exercise. What's the cost of exercise? Nothing. If you can walk like for 45 minutes every day, you can prevent yourself from stroke. So low salt diet, don't put a lot of salt in your diet, no smoking or tobacco, and exercise every day. If you have no money, you just do three things, your risk of stroke is down 50%. No medications. So for a poor person who cannot afford any medication, who cannot anything else, they just do these three things. But if you have high blood pressure or sugar, there are low cost effective medications for low income countries too.
Please, sir. Thank you very much. We will first complete the panel discussion, then we will take the questions from specialized speakers. Now, I'd like to ask from Professor Usama Yassin. He's from the Egypt. That shed some light on how is stroke care in Egypt, and are stroke units present, and how frequently TPA is given.
Thank you for the question. I think this is a very hot topic regarding the stroke patient, how to be managed in low-income countries and low or middle-income countries. I think one question that has been asked from the audience about the how to create stroke centers, and I would like to start by commenting on this question. I think so many models can be used or utilized to increase what's called the stroke surface, specialized stroke surface. For example, clustering model that we are using so much in Egypt. And clustering model include one center which is already developed and established a stroke care of surface at the maximum, and started to create connection between different nearby hospitals or facilities, and take the responsibility and the charge to increase the standards in these spots or spokes. And I think this models is starting more and more to show a success in increasing the number of stroke centers in Egypt. I can say, for example, we started about since 2013 by 4 or 5 stroke units. Now we already have 17 stroke units in all countries. So I think one of the models that can help in creating a stroke unit or specialized stroke center is a clustering model or integrative model, and it is not shameful if you can utilize the private hospital, because I hear from the audience that in Pakistan, for example, you have 10 stroke unit. Majority of them are private hospital. It's okay to use this private hospital or private sectors to increase the standard in other public hospital, because I think most of the workers in the private hospital are coming from university hospital. I think this is the scenario which is very common in most of our countries in the region. So I think that using this model can help increasing and disseminating the concept of a stroke unit in our region.
Okay, Professor Osama, is TPA provided by the government in Egypt?
Excuse me?
Is TPA, Altiplace, provided by the government?
Yes, TPA is provided by the government, and also mechanical thrombectomy is provided by the government.
Free of cost?
Yes, free of cost.
Thank you, Professor Mehdi. There is a question related to Dr. Professor Asfar, but I would like to ask from Professor Abdul Malik first, that how can we establish stroke units in public sector hospitals, and what is preventing us from it?
What is the preventive?
What then is preventing us from making more stroke units in public hospitals?
Thank you very much, Dr. Sajid. Actually, as far as the stroke care is concerned, no doubt the stroke unit is a very, very important component to provide a good quality stroke care. As we all discussed earlier, and even Dr. Anjum elaborated that although we had a 10 stroke unit, but it is very important what sort of services and what sort of care we are providing. So in our public sector setup, it's unfortunate that maybe in some public sector in major city like Karachi or Lahore, things are providing, but in majority part of the Pakistan, things are not at par in terms of human resource, because in some institute neurologists are available, in major institute, even in Karachi, we don't have a full-time neurologist where TP is providing like in NSCVD. So things need to be addressed in multiple level. One, the availability of proper trained person in where we are going to establish a stroke unit, a neurologist, and who shall be trained in terms of providing the TPA and the availability of TPA as well. So, and the most important thing, as you also asked the question to one of the panelists, that the cost is very, very important as far as we are concerned. Very limited person can able to get the TPA in a proper cause in a private school, but in a majority part of the Pakistan, where stroke is occurring, people cannot afford the cost even, and that's the reason that the stroke care or stroke unit, maybe in my opinion, maybe I'm wrong, that things are not establishing at what we want to provide stroke care. But beside this, with this stroke unit, we need to have a very strong, keeping in view our financial and economic circumstances, primary preventive and primary preventive measures in terms of across the board, in terms of blood pressure control, sugar control, and obesity, and these things. In this, we need to play the role in the community, in the rural area, in the different part of the world, because majority of the population even don't know that whether they are hypertensive or not. They got the stroke, then they came to know that they need to take the treatment, or they need to take the pigeon blood. These are the different practical aspects which we come across in our society. So as neurologists, as neurology community, as providing a proper advocacy to stroke, we need to work, no doubt we need to establish stroke unit across in the country, in the major teaching institute, but we need to more focus on the root level, which is for the primary prevention of the stroke, so that we can at least as much as we can lower the burden of the this disease. And even we are the young nation, but we if we can't stop this pandemic, we may produce a means a handicap more young people in our society. So stroke unit are no doubt important, but we need to work on more on the primary level.
Very much right, Professor Abdul Malik Saab. Another thing which I believe is that in many hospitals, in public hospitals, most of the stroke patients are admitted in medicine service. I think first they should be admitted in neurology service, then we can talk about stroke units and preferred care, because the medicine will people treat stroke not like the neurologist treat them.
Dr. Sajid, जी डॉक्टर
जी डॉक्टर अंजुम बोले।
नहीं आप इसका आंसर देने फिर मैं
My point is that this is the basic question which Dr. Sajid had asked, because we as neurology community and also as a stroke specialist, we need to advocate ourselves or present ourselves so that things can be whatever, who is who. It is not possible that you can treat directly to diabetes and hypertension. No cardiologist even can allow any neurologist to do so. But cardiologist, this is something we as a community need to, as a specialty, need to advocate ourselves, need to decision makers, lawmakers, to present and to complete. This is the task which as a society means Pakistan Stroke Society, Pakistan Society of Neurology need to work so that care, as you told, that at the end of the day, patient care is very important. And patient care will be important by the person who trained for that. So neurologist is the main person who need to take the lead to treat a stroke patient. No doubt other specialty needs help, as these help will be needed for other specialty as well, for treating other cardiac or metabolic diseases. But for stroke, neurologist, neurology department, stroke unit, this is the basic key so that things can be addressed on a quality care model or on an evidence-based medicine model. Otherwise, maybe patient will be treated whenever there will be no neurologist in Pakistan. Patient may be treated with the stroke care as well. So things can be done in that way. But if we want to give a quality care to our people, to quality care of our nation, we need to address in a holistic approach so that first of all, neurology department shall be established in a teaching institute, and this shall be mandatory a neurologist in a teaching institute as a part and parcel, as a prerequisite from the Pakistan Medical Council.
Thank you very much, Professor Abdul Malik. Now I will request Dr. Anjum Farooq, the President, Pakistan Stroke Society, for her concluding remarks.
Thank you, Dr. Sajid. Thank you so much. I'm honored to be a part of this symposium, which was on maintaining stroke, improving stroke care in low and middle income countries. And we know that there is evidence that increased quality of care during early phases of stroke is associated with decreased mortality, decreased morbidity, and increased functional outcome. But the quality of care, it has varied globally. High income countries, they have very better quality of care as compared to low and middle income countries. Even within the same country, we see that the inequality of stroke care exists. And as Dr. Basse told that the 3% of people in low and middle income countries, they become disabled, and mostly because of stroke. So this is a very, a big number. In our country, I have already mentioned that our stroke patients, they are 5 to 10 years younger than their Western counterparts, and we have very few stroke units. We have few centers that are offering thrombolysis and mechanical thrombectomy, and the patients are very few number of patients are receiving patients at the patient level, mostly the patient, they're not aware of their risk factors. And even if they are aware of their risk factors, they cannot afford medication. They're basically non-compliant with medication. And Dr. Vasi also explained this, that most of the patients, they have to travel a long distance to seek medical attention, sometime distance for the 24 hours they have to pass. So this is also a very important thing. In this regard, I think the most important thing is in low and middle income countries is to work on primary stroke prevention. That is cost effective. I think that is very important. And for that, obviously, the control of high blood pressure, diabetes, and all these things is very important. And at the same time, the second thing is to identify the barrier of which is actually providing hindrance for improving stroke care in these countries, and then addressing them properly, making strategies to improve stroke care in all those countries. And the most important thing is to make and to establish our own guidelines, which are according to our own circumstances, according to the affordability of patients. So this is very important. So today seminar was very important in that aspect, that it will help us to take important steps for making strategy to improve stroke care in low and middle income countries. Thank you so much.
Thank you very much, Dr. Anjum Farooq. With this, we end our today's seminar. I'm thankful to all the speakers as well as our audience, both physical and that joined us on Zoom, for their time and attention. We hope you had a very enjoyable session. Thank you very much. Allah Hafiz.